Good morning and welcome to Aging Matters. This program is provided by and sponsored by the Berks County Area Agency on Aging. My name is Ann Barlet and I'm the Public Advocacy and Outreach Manager for the agency. Our show today is on heart failure, and my guest is gracious with us today to spend some time to share information on heart failure. This is Skye McDonnell, and she is the heart failure, I always have a hard time saying that, program manager for the Reading Hospital. Thank you for being here, sharing this information. We have a lot to discuss, so thank you, Skye, for taking the time to do so.
Thank you for having me.
So, we were talking a little bit before the show about heart failure, and I was like, well, why, and kind of really what we're doing this for. And it's interesting that we still know that heart issues, heart failure, heart disease are still big issues, and we're bringing it here to Berks County is still a big issue in Berks County as well as nationally. And I think that, whether it's related to what we do and what we don't do in our behaviors, that heart failure or heart issues is typically a progressive disease that we're going to have. And so managing it is really the key to everything. And so I think we want to start right away then is, what is heart failure, Skye?
Yeah, so heart failure is a chronic, like you had said, progressive disease. It is something that it keeps growing in terms of numbers, nationwide, worldwide. It is becoming a huge issue. So it's really important for people to really understand how to manage it at home, to prevent hospitalization, and I think we'll get into that eventually. But heart failure is when your heart is just not pumping correctly. So either it's a very weak heart or it is a very thick muscle of a heart, so it could be a filling issue or an issue with the amount of blood that's being ejected from the heart with each beat. So it's either too weak or there's too much muscle there and it can't fill appropriately, and the tissues and organs throughout the body are just not being nourished with blood and oxygen. So it leads up to a backflow of blood, which causes all of the symptoms that accompany heart failure. But being able to recognize those symptoms, stay on medications and be compliant with those medications and diet, they're a huge part to successful treatment and prevention of exacerbations.
Skye, I think one of the questions I wanted to ask is, do you think people are complacent? I mean, you mentioned, one of the things is to kind of recognize whether it's, gee, I got a little bit more exhausted when I did that walk today, or going up to the steps in my house or apartment, I breathing heavier. Is it just something you think we tend to write off either because we are older or did too much that day, and we don't take it as an issue that we need to get checked? Do you think that's some of it?
Yeah, especially with shortness of breath. I think that as you start to get used to a certain normal, right? So for myself, I'm 34. Can I run very far? No. But I'm just used to that. But there are some people that, kind of they have that as a normal. And then as they start to live with this disease process and they have just that constant shortness of breath, that becomes their new norm. And so small changes in things like, increased shortness of breath, they may not notice it. It just might be something that they're like, oh, I've been this short of breath for a while now, but you just don't realize it until it gets to the point where it's really bad and that requires a hospitalization.
Well, and one of the things that, as you were saying, with inefficient, pumping to get to the organs, we don't notice that. You know what I mean? That's not something I can see. It's not, oh, I have a new spot on my hand. Might be skin cancer that I'm going to watch, and I can see it, and it might grow or change color. You don't kind of see that either, right?
Right.
You're not aware.
So we have heart failure zones is what we call it.
Okay.
So it looks like a stoplight. I should have brought a picture. It looks like a stoplight. So green zone is where you're feeling your best, right? You're waking up in the morning, you're really not feeling that short of breath, not noticeable anyway. You slept fine. We encourage people to take their weights every day. And that's one of the very first things you should be doing in the morning, because that is subtle increases in weight over a period of time is what you want to monitor for. So when you're using the zone, you're taking your weight, you can really kind of classify yourself as to I'm doing okay. The yellow zone is when you're starting to maybe have some symptoms. You might not notice all of them, but your weight is slowly increasing. And then the red zone is when you're really feeling really not so hot.
You're definitely experiencing some
you're
changes.
Having some trouble laying flat, even having to sleep in a recliner, or maybe using a couple of extra pillows. Things that you kind of change in your own personal daily process that you may not notice. But when you are forced to stop and look at that red, yellow, green stoplight chart, it's one of those things that you're like, oh man, I'm in the red and I wouldn't have even thought. So when we use that, we tell patients usually when they're in the yellow to call the cardiologist or whoever manages your heart failure medications, because they'll be able to prescribe you maybe outpatient diuretics. Either maybe an IV diuretic, they might bump up your dose of a medication to kind of help with those symptoms to avoid that hospitalization.
So I have two thoughts on that. You talked about the zones, are there types of heart failure, or is this all, I think of folks that I know I've read and seen, or they'll say they have congestive heart failure. Is that one type? Are there different types? What do we do? And then the second piece is, how do I then find a cardiologist if I don't have one? So let's say I'm not, I'm beginning to, I hear this today, and I'm conscious now of the 3 types of zones, and I might be in the yellow one, so that's kind of the time to seek out. So help me to do that too before we even move further.
Yes, sure. So when someone has heart failure, they can either have what is called a systolic heart failure or a diastolic heart failure. There's some in between in there, but those are the 2 primary types.
Okay.
Systolic heart failure, you're going to have a very weak heart muscle, and that really has trouble ejecting all of the blood out of the heart. So there's going to be some blood left over in your ventricle, and it just kind of gathers, blood clots and leads to other issues.
Okay.
But the main part of that is you have this weak muscle. On the other side, the other side of it is diastolic heart failure. So with diastolic heart failure, your heart muscle is too thick. So you don't actually have enough space for blood to fill in the ventricle to be pushed out to the rest of the heart. That type of heart failure is becoming increasingly common. It's commonly associated with hospitalizations and readmissions. And I think it's going to be progressively worse with time. And it's a little bit harder to treat, that one. So we, just kind of staying on top of that and really recognizing those things is huge. So yes, there are different types, but a blanket way to look at it is that they all cause a backup of fluid.
Okay.
So in a sense, yes, there are different types, but very similar symptoms.
Okay.
If someone feels that they are having issues and they need, in terms of treatment for heart failure, maybe they're showing all these signs and they're like, there might be something wrong, and they don't have a cardiologist, I would say really reach out to the primary care provider, and they'll be able to do the same diagnostic tests and send a referral to a cardiologist.
Okay, good. So what, I guess, do you want to talk about, I think we want to talk a little bit about then what they might do as tests, because everybody's scared, and everybody, you kind of want to know, but you don't want to know, and you're not sure you want to go through testing. So what tests might be done then to help determine some issues surrounding the heart for someone?
Sure. So usually when you show up to your primary care provider and you're having issues with shortness of breath, they're going to order maybe a chest x-ray. They're going to take a look and see if there's some fluid in the lung space, and that'll give them a better idea of the real issue, because you can have shortness of breath with just about anything. And now we have COVID, and it's RSV season, and it's flu season.
Fluid, yes.
I mean, so you can really have shortness of breath for anything. So it's a very vague symptom. But they're going to take a look at fluid in the lungs.
Okay.
They're also going to look for maybe the size of the heart. They can see that on a chest x-ray. That'll show the diastolic heart failure that I was showing with that thick muscle. So it's going to be a little bit displaced in the chest. So they might notice something there. Labs, they can draw all kinds of labs.
Okay.
They can show all kinds of things. So those are always fun to kind of look at and sift through. But the primary test that they're going to do is an echocardiogram. With an echocardiogram, it's looking at the size of the heart, the structure of the heart, and really it'll measure how much blood is pushed out with each beat, which is called the ejection fraction. So you'll hear me say that over and over again. I'm so used to talking about this, but you know, with each beat, your heart is supposed to pump out a little over 50% of its blood volume. So when you have heart failure, like a reduced ejection fraction is what they call it. Like I said, there's about 1,000 names for all of them. But when you have systolic heart failure and your muscle is weak and you have the very thin wall, usually you're getting less than 40% of that blood volume. Now, with diastolic heart failure, you're still going to have that kind of a normal ejection fraction because it's still pushing out all of the blood that's in there. But the problem is more of a structural issue, like the thick muscle wall and everything else. So you're going to see different things on an echocardiogram, and that's really going to give them an idea of kind of where to go from there. If someone has a reduced ejection fraction or systolic heart failure, they may order additional testing, because usually the cause of systolic heart failure is maybe a lack of oxygen to the heart itself. So after a heart attack, we'll usually see that. Sometimes a cardiac catheterization, they'll go and place a stent to kind of increase oxygenation to a specific area of the heart to really help it to function better. So they really look for the cause, and then they treat it after that. So that's the primary way that things go.
None of them sound too difficult or too trying.
No, I mean, it is. There's very specific guidelines for how things need to be done. It's like step A, step B, step C. Yeah, it's very interesting.
So now, moving forward, I guess we can talk about things that, in addition to, now we've got the test done, we probably now have a cardiologist as well. How do we treat that? You know?
Medications.
Okay.
So there is no cure for heart failure. And I think that is something that is not emphasized
So it won't go
enough.
away. It's chronic. It's going to be with us. We're going to best manage it.
Right.
Okay.
It is a chronic progressive disease. But it can be managed if you're taking the medications that are prescribed, you're following up and communicating with a provider. That is huge. That back and forth communication of your symptoms and your weight gain, or wherever you are on that scale, the communication is huge. And diet, which everyone loves to talk about diet. Everyone
so
loves
you talk about diet. I guess we have to. Did you notice I was avoiding that? No. So we have medications to help, but you're saying diet, and I heard you say weight gain and things. So give us the correlation, and then what we should be doing as we look at our diet, or I'll call it a nutritional plan. How's that?
So, the heart pumps fluid, right? So when your body holds on to it, you're going to see a weight gain, and I avoid stepping on the scale because of that. There can be a very small change in weight because of fluid. Okay. So we call it the fifth vital sign is your weight. Your weight is the fifth vital sign. You have your blood pressure, your heart rate, everything else, and then weight for heart failure patients, because that's going to really be what stands between just a normal day and a hospitalization. You have patients that can go days or weeks and not take their weight at all, and then you ask them when they come in, and they're like, oh, I haven't taken my weight. And I'm like, this, if you would have, I usually will sit with them and I'll say, if you would have taken your weight, back 2-3 days after you got out of the hospital the last time, then you wouldn't be here. Because we have so many resources outside of the hospital to really help get rid of that extra fluid without requiring that long hospitalization. So
what can we do in terms of diet?
So nutrition in itself is focused on sodium for heart failure, because wherever sodium goes, fluid goes. So when you have an increase in sodium, your body is going to hold on to fluid. So our goal is not to cut sodium completely, but just to really decrease it. Now, we recommend, I believe it's less than 2,000 milligrams of sodium a day.
And all of us go, okay, whatever, because we don't know what that is.
No.
We have to put that concrete so we understand or see it. Okay, here we go, a teaspoon.
A teaspoon of salt is 2,300 milligrams.
Okay.
So I don't know how I remember that. It's just kind of stuck in the back of my head. Because it is. When you look at it and you see it and you're like, man,
that's a very small amount for
and
people.
So the majority of sodium comes from added salt. So what we tell patients is to just keep the salt shaker off the table. Really become a master at reading labels and be aware of how many servings per whatever you're eating. Because some cans of things are they'll have multiple servings in one container. So just be very aware of that.
Because a lot of the foods, I believe, that are higher in sodium, and we've talked about this with different nutrition programs, is that seniors, a lot of times either they're living by themselves, living perhaps on a fixed budget, and so we know that certain items are more expensive than others, so we tend to go to simple, easy to make, not too expensive, which could be canned soups, or the quick make hot dogs, the prepackaged meals, which are all higher in sodium, are they not?
Right. Oh yes. Okay. Oh yes.
So I think that's great that at least be somewhat mindful of the portion size, the amount.
Yes, and a good rule of thumb is to stay on the outside ring of grocery stores. Anything that's in the middle and is kind of sandwiched in between those aisles is usually in there because it's processed, it's full of sodium, just to maintain that shelf life. So being able to shop around the outside and do the fresh fruits and vegetables as much as you can. Try to season some things with either Mrs. Dash.
Okay.
Or you could use fresh herbs, different juices or spices. Usually that will
It'll help make it
yes.
somewhat more tasty because, again, we lose some of the taste buds as we age. So I think that's kind of the conscious, unconscious way that they're going to add salt is because it doesn't taste.
Right.
And then nobody wants to eat. So we want people to eat, but we can use alternatives.
Right. And, it's just as important for families of individuals to know this too, because especially around the holidays when, we're not always in control of what we eat over the holidays.
Yeah.
We have people that are making things for us, or they're bringing them, and just saying, here, I made this for you. And you feel so bad saying no. So, and that's okay. You can have everything in moderation. That's the key.
Okay.
And just making sure that, around the holidays when you're eating all these extra high sodium foods, making sure you're taking your weight and communicating with the cardiologist who will help to kind of manage those increased symptoms that you may have because of changes in diet.
And is this a good thing or is it a bad thing for somebody having heart issues is drinking more water?
So fluid restrictions are hard because it all depends. It all depends. It's the same thing with medications. It all depends on the patient.
Okay.
There are different ways to treat heart failure, absolutely. Fluid restriction is definitely one. If you're noticing that you're gaining weight, maybe cutting back on a little bit of the fluid. We usually say a 2-liter fluid restriction for heart failure patients, but depending on other things that the patient may be going through from a health perspective, they might not be as strict with that fluid restriction. So it's definitely, I would say, to get that plan in place with your cardiologist, your primary care provider, so you have a better understanding of where you are. Again, it all comes back to communication.
Mm-hmm. And I think the uniqueness. So that's why it's so important to be a self-manager, to be able to recognize that all the way along, recognize the issues, the symptoms, the zone you're in, seek out your primary care doc, the testing, cardiology, follow your specific treatment. So whether it's the medications, the type of diet, the weighing, those kinds of things are unique to you, and to make sure you're a better manager.
Yes, and I always say you're the driver, right?
Okay.
A patient is the driver of their own illness or disease process, or whatever it may be. You are your biggest advocate. So when you go in and you have your appointments, and you're just stay organized as best as you can, try to stay as organized as you can. Really focus on getting everything in one place, your medications, really advocating for you and what you need, your goals. It's huge, being able to say, this is what I can afford, right? Back to the
Absolutely.
diet, saying, this is what I can afford, this is who gives me my meals, what can I do? We have registered dietitians, we have advanced care plan coordinators. They'll help you work through whatever goals and diet plans that you're able to do.
Terrific.
So there's a lot of resources.
Good. And we mentioned at the beginning, you were saying about could lead to hospitalizations and a lot of rehospitalizations when we're not managing it better or didn't even recognize it. So as a representative of one of the hospital, Reading Hospital, why are you looking to share this information? What's going on? How do we prevent some of that, I guess, readmission, or share information about that with us?
Absolutely. So readmissions, they are a huge cost issue for not just for this area, but everywhere. That's one of the primary causes of this increased financial stress for hospitals, but at the same time, it is patients.
Yeah,
patients
absolutely.
suffer terribly.
Yeah.
We want patients to spend more healthy time at home. That's my favorite saying. Healthy time at home.
And not in the hospital.
Yes, because that's when you're going to be living that quality life, is when you're doing what you want to do. And that's our goal, is to help that. And on top of that, every time a patient is readmitted for heart failure, their risk of 1-year mortality increases by 50%, which is huge.
Yes.
Not everyone realizes that, and I think that's a statistic that isn't said enough, because that is why we do
then.
it. Okay, so
slower for us people.
So every time a patient is readmitted for heart failure, their risk of 1-year mortality increases by 50%. There's a 50% increase in 1-year mortality, and that is huge. So pushing that, staying home and being healthy is not just because we want everyone to have this great quality life. We want to, but at the same time, we want you to live a long life, quality and quantity, not just that quality piece.
Yep. Be mindful of yourself, the management, and don't give up. And why would you want to spend time in the hospital if you can avoid doing some of the things that we talked about? We have a few minutes to talk about some resources that are available here in our community for individuals with heart failure situations beyond, I guess, the cardiologist per se.
Yes, absolutely. So we have, like I said, we have our advanced care plan coordinator. Wonderful human being. She will sit and go over goals. Advanced care plans are really looked at kind of in a negative light, because you're really planning ahead for worst case scenario, and that's not always the case. We're really just sitting down and saying, what do you want? What do you want? And how can we get that for you? And that's kind of where everybody should start, right? We have our Tower Health at Home, which is our home health agency. They are wonderful. They really put a big focus on heart failure, and we've been working very closely with them on our heart failure team to help to educate patients on an outpatient basis, get that transition of care piece, kind of a smoother transition of care, and they'll be able to help organize to really develop a plan so patients are able to care for themselves at home. We have our community paramedicine program, wonderful. I can't speak highly enough of them. They're wonderful people. They will go out very frequently and visit patients just who, they may already have, home health care visiting them.
Okay.
But they'll come in on the off days that home health care isn't there, just to kind of check in, to say, hey, what's going on? How are you feeling? And they can help communicate with a cardiologist. Our biggest thing right now is remote monitoring. And that is, in part helped by the community paramedicine program. I mean, they're wonderful.
Yeah, and some other issues, yeah.
But remote monitoring through STEL is the company that we go through. They will actually they'll bring the equipment to your house. It's just in a little tiny box. So I say equipment like it's just this big thing, but it's a tiny box, along with a blood pressure cuff and a scale. Every time the patient takes their blood pressure cuff, or their blood pressure and steps on the scale, that is directly transmitted to the providers. So they will help the patient not only to identify the symptoms, they'll have frequent phone calls pretty much
Can you really
almost
staying
every
on top
day.
of it? Yeah.
Yeah, and they'll help to get the help for the patient that they need and provide a direct link between the patient and the provider.
And I would think that that was some security in that.
It is a second
For
set of
the
eyes.
individual,
It is
yeah.
a second set of eyes because they'll find things that really aren't, we may not notice
Yes,
every day,
exactly.
like we had said before. Things that we may just become used to, and they'll say, hey, your weight went up by, 3 pounds today. How are you feeling?
Yep, good.
So it's great.
And we have about 1 minute left. So is there one last either resource available or help us to direct ourselves to better self-management?
Yeah, so I would say the importance of a routine is huge. Get up in the morning, step on the scale, measure your weight, keep it on a calendar. So you're going to be able to see that either progressive weight gain or that it's staying the same, taking your medications, and really focusing on diet and living a healthy life.
Super, terrific. Again, I would thank Skye McDonnell for coming and sharing this information. She is the program manager for the heart failure program at Reading Hospital. And should you have any other further questions, you're welcome to call our agency, the Berks County Area Agency on Aging, at 610-478-6500. You can ask for me, Ann, and I can forward that information to Skye. Or again, I think the recommendation was just make sure that you are monitoring, stay in tune with your primary care doctor, and if you have the heart issues, certainly keep in contact and call your own cardiologist because you are unique in the way that you are being helped with that disease. So again, thank you, Skye, for sharing this information.
Thank you.
And thanks for tuning in to Aging Matters.